Hey now, hi everyone. It's my pleasure to welcome Dr. Matthew Gillespie. He's a dentist in East Texas. He has interesting ideas about the future of dentistry, the future of healthcare, preventive dentistry, different payment methods. We are all frustrated with insurance companies and third payers and their intrusive practices. Dr. Matthew Gillespie has really interesting ideas about this.
Trick, thanks for having me. I'm just going to jump right in and give you a little bit of background on myself. I've been a dentist here in East Texas since about 2012. I graduated in 2010 from University of San Antonio, and my sort of interest is value-based healthcare. Is how do you pay a dentist to prevent the disease that they are preventing versus paying a dentist for simply providing treatment for the symptom like we usually do. There's sort of been an issue with insurance and third-party payers, like you mentioned, to where we're sort of seeing declining reimbursements. The problem with declining reimbursements, though, is we sort of have this financial pressure to look for profitability in the procedures that we provide. The hard part for a dentist is to understand that we sort of have these economic strings attached to us. And even if we don't want to admit it, they sort of pull at us at the back of our head, even when we don't realize it. One of the big things that I'm interested in is going forth in the future, we see third-party payers, we see the American Dental Association, we see the US government with Centers for Medicaid and Medicare looking for this value-based healthcare. What this drove me to do is sort of reevaluate what dentistry looks like. I went back and got a master's of business administration to try to get a better understanding of what dentistry looks like from a business perspective, because we know DSOs, corporate dentistry, are going to have a big part of the future of dentistry. I don't think we need to turn our back on anything. I think we just need to be open to different business models. And maybe the single independent dentist model can be improved upon. But if that's going to be improved upon, we need to understand that we still have dentists and patients as the primary stakeholders in this system. How can you reward dentists for avoiding disease? At the same time, how can we hold patients accountable for their lifestyle factors, their nutrition, their education, to ensure that they're doing their part to help also offset the risk? And then on the big part of this, we've seen with Obamacare, we've seen with the ACA, we've seen with third-party payers that insurance companies have to have their profit incentives aligned with both providers and patients if we actually want to make a bigger improvement in the way that dentistry is delivered in the future. So my sort of perspective is maybe we should actually try to align those goals more than we have now. I think we really need to take an open perspective on this. I think we need to look at dentistry from the insurance perspective, understand what they have to offer. I think we need to take what the DSOs are doing and seeing if we can incorporate their best practices into what the independent dentists are doing. And right now, I feel like there's this adversarial relationship with DSOs, with dentists, with third-party payers, with patients, and everyone's trying to fight for their own piece of the pie. But maybe if we just took a collaborative approach, we try to align the values for everyone, that we could all become winners in the long run. And so that's sort of my perspective. Layer on top of this, the advent of AI, artificial intelligence, machine learning, software as a service companies, we're now seeing greater influence from companies that we never thought we would have. We used to all have paper charts. We now have Open Dental, we have EagleSoft, we have Dentrix, we have Oryx, we have all these sort of data centers that are aggregating our data. And I think it's important that it's not lost that the data that they're aggregating are generated by the dentists themselves. We have layers of intellectual property rights. So if you really think about an intellectual property rights perspective from a dentist, insurance companies are using our clinical outcomes data to develop their financial tools. As of right now, me as an individual dentist, you as an individual dentist, Tariq, don't have a way to capture that compensation or capture that monetary value of our intellectual property rights that inform their algorithms to help develop these tools. There's so many different layers that as we go forward, even though the system is going to be simplified, it gets incredibly complex when you look at each individual person, entity, corporation, software system that's going to have a say in the way that dentistry looks like in the future. And I think that's sort of the issue that's being missed. Dentists like to hold on to the way things used to be. Corporations and insurance companies like to hold on to the way that things used to be. And one of the things that I'm seeing with value-based healthcare, a big critique from dentists is it looks like capitation. And
Yep.
so for those doctors that don't know, is capitation is you give a dentist a certain amount of money, you provide the procedure, and then you don't have any more money on top of that. So it's a very negative reinforcement. It's a punishment-based system. But what happens if I do well? No one is talking about profit sharing, healthcare-based incentives, longevity bonus. The only way value-based healthcare really exists in the future is if an insurance company says, hey, Dr. Gillespie, you've managed these patients so well, you've saved us money. And that's really what should be the case. If I do my job incredibly well as a dentist, I should beat the algorithm. And if I'm not beating the algorithm, then there's a problem either with the algorithm or there's a problem with my dentistry. And so as soon as I beat the algorithm, as soon as I beat the actuarial calculations, I should be entitled to a healthcare bonus because high quality work should last longer than average. And when it lasts longer than average, it both benefits the patient and it benefits the insurance company because my work doesn't have to be replaced at a frequent interval. But me as a doctor who doesn't have to replace the work gets the short end of the stick. If I'm not replacing that filling at 5 years or at 7 years, like the data shows, I'm not making any money. And if
That's right.
I have no money
Mhm.
coming into my dental practice to do high quality work, then I have no incentive to be better. And this has actually been shown in healthcare system. There is Baylor Scott and White did a study several years ago where they looked at outcomes for their surgical patients. As they reduced complications, they actually saw a decrease in reimbursement. So if you see a decrease in reimbursement and you're a huge hospital system, then you don't have a way to get that money back.
Can you explain to us what do you mean by beating the algorithm? And also another thing we want to agree on is that in dentistry, mostly the sick subsidize the healthy.
Yes. So with algorithms, so everything with insurance is actuarial calculated. So when you take a large group of patient population, say you have a filling placed at year 1, we know on average that that filling needs to be replaced at year 5. We know after year 5, sometimes that filling turns into a crown. That crown lasts on average between 7 to 10 years. If it has a complication, then we're talking about a root canal. Well, then we think that root canal and crown may last for another 7 to 10 years later, which then gets replaced with an implant. All these numbers and all these intervals are calculated for. At year 5, it's not like the insurance company loses money. It's not like the patient loses money. Individual premiums are based on knowing that replacement cycle. It's no different than homeowners insurance, healthcare, disability insurance. There's a saying in the financial world, if you can calculate the risk, then there is no risk. If we know 10% of the population has to have their fillings replaced at $500, then they simply calculate the risk, they calculate the future payouts, and they charge both the patients for this. They charge the doctors for this in terms of reduction or discounts that we're given. And then the insurance companies also have to account for this. So there's a certain amount of money that they have to hold back for their insurance premiums, knowing that they're going to have to pay out for future claims and losses. And we're seeing this in climate change with homeowners insurance. We just saw this in California with wildfires. They have to budget for these catastrophic fires. And so part of your premium goes for what happens if a wildfire hits California. The insurance companies have to have enough money in reserve in order to pay this out. So when I'm talking about beating the algorithm, I'm talking about all of these metrics are calculated by insurance companies. It's not an arbitrary number. They spend a lot of time, money, and effort. They have a lot of highly educated people to verify what does dentistry look like at year 1, year 5, year 10, year 15. And so that way they're not going to be losing money. Because if they lose money over the long run, then the system collapses and there's no money to go around. But what's unique about dentistry and healthcare, sort of taboo to talk about, is dentists themselves are a large factor in driving the progression of dental disease due to their own individual educations. As much as we don't want to admit, there is a difference between a doctor a year 1 out of dental school versus year 20 out of dental school. We should all be striving to get better. And once we get better, we should be better at managing the disease of our patient population. So the better you are at managing the disease, we should have a lower progression of disease based on our superior management of that disease. And so that's really what I mean by beating the algorithm. I want to beat the norm. And if you
Mhm.
beat the norm, then we should be driving savings for everyone in that system. Even though we're doing less work, sometimes that means increases in fees, implementing an in-house dental plan, which we're now capturing the insurance premium ourselves, or
Right.
longevity bonuses. And one of the things that I'm really interested in is if your restoration lasts longer than 5 years, we know that insurance company has budgeted to replace it. Well, what happens if they don't need to replace it? Currently, we don't have a mechanism in place to pay a dentist for a longevity or health-based bonus. And this is a big problem with value-based healthcare. A lot of value-based healthcare that we're seeing is negative reinforcement systems. If you don't do a good job, we're not going to pay you any more money. But what I want to see is if you do a good job, I want that dentist to have a bonus because that dentist has saved that insurance company money. That dentist has saved that patient money. In order to be a really good dentist, we should be doing less work in the long run. And our system now is set up in a fee for service. That means I collect a fee for delivering a service. We don't have a way to provide me a fee for avoiding a service. And that is what is the missing component is. How do you calculate what that fee for avoiding a service looks like? How does the insurance company get paid for managing the doctors to provide them with an incentive to be better? Right now, insurance companies know who the best and worst doctors are. We want them to have an incentive to go to the doctors that are underperforming and say, hey, these doctors are doing really well. Maybe we should look at those doctors who are doing really, really well, help provide them to give CE to the younger doctors to have mentorship. And if you take my data and you push it on a dentist who's only been out for 1 to 2 years, it's not fair to him. He's not going to be able to do what I can do. We have to give him the patience. We have to have room for growth. And if he can grow into that, then he's going to be a great doctor in the long run. He's going to save his patients more money than most doctors who are exposed to this. And over the course of time, any insurance company that covers any of his patients over a 15-year period of time is going to save a lot more money than a doctor that does year one of dentistry for 20 years. We don't want to get in this feedback loop to where we're doing the same thing over and over. At the same time, how do you reward patients for taking personal accountability of their own disease process? And that's one of the things that we talked about previously in healthcare. It used to be that if you were a tobacco smoker, your healthcare premiums were different than if you were a non-tobacco smoker. We don't want to condemn those patients, but at the same time, we want to reward them for making good healthcare decisions that not only benefit them, but also benefit United Healthcare, that benefit United Concordia, that benefit Blue Cross Blue Shield, but also ultimately benefit the U.S. taxpayer. Everyone in the United States age 65 becomes eligible for Medicare. So once we start going into a taxpayer-funded system, it's much cheaper for us as taxpayers, for us as funding the federal government, to have a healthier population. What we need to do is we really need to understand that we're all in this together. It's up to you and I, dentists in our prime age, to be able to support those retirees who don't get that benefit anymore. So this transcends dentistry.
Here's my question about this, because that's the conundrum we're in now. As I said, the sick subsidize the healthy. We're incentivized as dentists to treat disease. You want to do something that's good for the public. The public benefits, the taxpayers benefit. Preventive care, restorative care. You've had beautiful studies that you posted on Facebook about your restorations and how to fix defective restorations and make them last, still with direct restorations, to the point that you were even audited by one of those insurance companies. Can you tell us a little bit about that? How do you think we can incentivize dentists to go that route of simple restorative preventive dentistry more so than big procedures?
So I'm a member of 3 to 4 different dental groups: Dental Clinical Pearls, Dentistry in General, Kumandra Doctors, and Alliance of Independent Dentists. I'm also on Dental Nachos. My interest, like I said, is value-based healthcare. So what I started doing is I had a mentor who has since passed away named Gerald Benjamin, who was posting these long-term cases. He was posting these direct composite restorations that were lasting 25 to 30 years. So he showed me his cases. Then I looked at my own work and I said, you know, my cases weren't lasting that long. And he said, this is not you. It's a technique. You may not have been trained the way that you could be trained. So why don't you look at what you're doing from a different lens and start looking at doctors who have cases like mine? So I went on a international journey. Another one was RIPE, which is Restorative and Implant Practice Excellent, which is an international group. I started looking at European, Asian, Middle Eastern dentistry, and I realized dentistry in the United States looks vastly different from dentistry outside of the United States. And then I came up with a quantification. It's the old epidemiological restorative index, which is the DMFS scale. Once I started looking at quantifying the progression of dental disease in other countries, I realized maybe we're a little bit more aggressive. Maybe our fillings aren't lasting as long as they could. Maybe our crowns aren't lasting as long as they could. And so what I did is I found mentors all across the world. And I said, what are you doing differently than I? And I studied their clinical techniques. I looked at the restorative materials that they were using, and I made a change in my practice. And so when I made a change in my practice, I saw a reduction for crowns by about 50%, saw a reduction in root canals by about 50%, and the same thing for extractions as well. The hard part is I had to change the way I charged for my dentistry. So in the United States, most dentists are not responsible for selecting their own fee schedule. And this gets to be a little bit of a gray area. When we start talking about how dentists charge for their fee schedule, we come into this political conversation of antitrust laws and collusion. How do you charge for work when we're supposed to be in competition? The problem with the way the politics looks at dentistry is they view us as in competition. I don't view you as my competitor. I view you as a collaborator. If you do good dentistry and I can teach you to do good dentistry, your patient population, which is nowhere near my patient population, should have better healthcare outcomes. If you can generate better healthcare outcomes, we should all create more value for the system that ultimately benefits taxpayers. What I'm about to say is something that may be controversial, but you have to be able to calculate your own fees without having an insurance company, a third-party payer, or the U.S. government dictate what your fee should be. Those entities are not in our own business. You have to be very educated on your own business. You have to know your own overhead. You have to know your own direct clinical costs, and you have to know your own time involved. And so what I was realizing is there's certain procedures in U.S. healthcare that are inherently more profitable than others. And dentists may not realize this, but they're drawn to those procedures because they're not allowed to set their own fee schedules. We're not actually taught how to set our own fee schedules. If you were to have a CE course sponsored by the American Dental Association where I teach a dentist how to set their own fee schedules, there could be a lawsuit involved for the American Dental Association by a third-party payer saying what this doctor is doing is collusion. This is antitrust. That's not the case. We're trying to develop better outcomes for everyone. If you do what I'm saying, the insurance company ultimately benefits, the taxpayers ultimately benefit. I started looking at maybe I wasn't spending enough time on basic dentistry because I wasn't paid well enough. And when you have a procedure that you're not paid well enough to do, you cut corners, you rush. And when you're paid $50, $30 to do a procedure, and the average overhead in the United States is $600, you're going to rush that procedure. If you rush through that procedure, it's not going to last as long. We are paid to rush on certain procedures. We are paid to slow down on certain procedures. And if we take that into account and we actually account for that, go slower on those simple procedures, then they're going to last longer. And if you start increasing your charges for those simple procedures, they're going to last longer. They're still going to make that insurance company money. But then you have the conundrum. If you accept an insurance contract, you're not allowed to develop your own fee schedule. Developing your own fee schedule based on your time and quality has to be done outside of a system that is dictated to you. And that is the problem. If we have 85 to 90% of doctors contracted with insurance, it skews our pattern of practice and we don't even realize it.
So this is a very important point. You said 80 to 85% of dentists are contracted with insurances. Most of us would like to get out of insurance one way or another. Some of us are out of network, some of us are in network, some of us choose the networks. Are you suggesting that we all leave insurance like everybody wants?
I'm suggesting that we become educated in understanding how time and quality and longevity actually affects the profitability of our dental practices. And if you cannot account for time, if you can now not account for quality and you cannot account for longevity, then you're stuck in a pattern of practice that you can't alter. And that's where 85 to 90% of doctors are. Insurance companies don't understand this either. I got flagged for fraud for doing too many big fillings. I called a number of insurance companies. Thankfully, the past dean of my dental school at University of Texas in San Antonio was on the board of MetLife. And he said, Dr. Gillespie, I understand you're upset with this. Let me get you with one of our clinical directors who can go over with you your clinical pattern of practice, which you were flagged for fraud for. And I said, I was flagged for fraud because I did too many 3 to 5 surface large direct composites. What they said is I use these large direct composites 69% of the time as compared to 24% of the time by the average dentist. And when I mean the average dentist, there was over 97,000 other dentists in their database that they compared me to. So I did this procedure 3 times as much as 97,000 other dentists here in the United States. And I said, why was I flagged for fraud? And he goes, what you need to understand is our algorithm catches patterns of practice that are outside the norm. And so when a dentist does a class 2, an MO or DO restoration, what they have a tendency to do is bill out an MOL, an MOB, an MOD. They add an extra surface because we all know we get paid based on the number of surfaces. They realized that I was possibly gaming the system, which wasn't the case. When I showed them my cases, I said, let's start talking about my other utilization. I think I'm saving you more money. And then we had this whole conversation of, if you have my data, then give me my other utilization data. And it was one of those things that he said, I'm sorry, Matt, I can't do that. Your utilization data is the proprietary business intelligence of MetLife. And that really rubbed me the wrong way. You're telling me my clinical patterns of practice are your proprietary business intelligence, but they're my proprietary clinical patterns of practice. Why are you not compensating me for that? But you're holding it against me. And as soon as I'm showing you how I make you more money, you're going to now become shy with that data. And this is not just for dentists. This is for insurance companies to understand they already have this data. They can help drive a better pattern of practice. They can help drive the education if their incentive structure was based on our incentive structure, which it isn't. What I'm saying is if we shrink the entire industry of dentistry by 50%, insurance companies probably stand to lose more money as a corporation than we do individually. And that is something that was really hard for me to understand. At the same time, if an insurance company is giving me the same fee schedule as you, it's not fair to you, and it overcompensates me because you have unique expertise that you should be rewarded for. And if an insurance company came to you, Tariq, and said, hey, you know what, you do this better than 90% of the other doctors out there. Tell me, look at these other doctors like Dr. Gillespie, who doesn't do this very often. How can he improve? If they came into a collaborative relationship with the best doctors in the field in each individual specialty, we're talking about prosthodontics, pediatrics, orthodontics, oral surgeons, then those premier doctors would actually have a more positive relationship with the insurance companies. We would see greater fees. We would see less complications. We would see greater profitability for everybody. But I just want the doctors to understand that value-based healthcare is not a scary topic, that corporations shouldn't be adversarial in nature, that insurance companies shouldn't be adversarial in nature. If we could work together, just sort of reimagine the system, I think it benefits patients, doctors, insurance companies, DSOs. I think there's more of a collaboration of care. Currently, right now, with the third parties not having a true way to capture what I'm talking about, they don't have an incentive to change the pattern of practice. And for the lack of better terms, we're starting to see cookie cutter dentistry. We're seeing cookie cutter insurance plans, cookie cutter DSOs, cookie cutter private practice, patterns of practice. And I don't like that. It's a race to the bottom. We should be rewarding innovation. We should be rewarding clinical outcomes. We should be rewarding longevity. We should be rewarding health. And in order to do that, you have to pull the entire carriage in a single direction. And we're now all running in opposite directions. We have to align values. Currently, none of our values are aligned. And if we can do that, we're all going to be better off. And if we're not, we're all going to fail independently. And that's the direction we're headed. And that's my fear.
That's very good food for thought to be left. Dr. Matt Gillespie just mentioned some really good ideas. Let's talk about them. Let's have a conversation. We want to get you back, Dr. Matt, along with Dr. Amy Adair. I think it would be a really good conversation if we can get both of you.
I really appreciate it, Tariq. I look forward to it. And like I said, you can find me on those 3 groups.
Thank you so much for being with us, Dr. Matt. I appreciate it.
Thank you.
Thank you.